Council executive budget hearing on the Committee on Finance, joint with hospitals. At this time, please silence all electronics and do not approach the dais. If you are testifying today, make sure you fill out a slip at the back of the room with the Sergeant at Arms. Chairs, you may begin.
Thank you, Sergeant. Okay, good morning and welcome to day 9, I believe, of executive budget hearings for FY26. I'm Councilmember Justin Brannon. I chair the Committee on Finance and will be hearing today from New York City Health and Hospitals Corporation. And I'm pleased to be joined by my good friend and colleague, Councilmember Mercedes Narcisse, who chairs our Committee on Hospitals. We've been joined this morning by Councilmembers Palladino, Brooks Powers, Lewis, Carr, Salam, and Gutierrez. Welcome, President and CEO Dr. Mitchell Katz. It's always good to see you and your team. Thanks for all you do, and thanks for joining us today to answer our questions. I always like to set the table before we start. Back on May 1st, 2025, the administration released the Executive Financial Plan for FY26 to 29, with a proposed FY26 budget of $115.1 billion. The Health and Hospitals Corporation is not a city agency, but under agreement with the city, they do receive a city subsidy to administer new programs. H&H's proposed FY26 subsidy of $1.70 billion represents 1.5% of the administration's proposed FY26 budget in the executive plan. This is a decrease of $579.2 million, over 25%. From the $2.28 billion that was budgeted in the preliminary plan just back in January. The decrease seems to result from several actions, mostly a net reduction of asylum seeker funding offset by increased funds for the H&H collective bargaining agreement. The Council's preliminary budget response called for additional funding to support a range of mental health programs, women's trauma-informed care, outpatient support at Lincoln Hospital, a health psychologist in each of H&H maternal health departments, along with a call for a new trauma hospital on the Rockaway Peninsula. At this point in our city's history, especially when it comes to mental health, our neighbors need us to meet the demands of the time. We can't afford to fall short. My questions today will largely focus on H&H's utilization of city funds, school-based health and mental health centers, and vacancies at various H&H hospitals. But I now want to turn it to my co-chair for this hearing, Councilmember Narcisse, for her opening statement.
Good morning, and thank you, Chair. Good morning to everyone. And I am Councilmember Mercedes Narcisse, Chair of the Committee on Hospitals. Thank you for attending today's hearing on the city's fiscal 2026 executive budget for New York City Health and Hospitals Corporation, or H&H. I would like to thank my fellow council member, Chair Justin Brannon, for joining me for this joint hearing. I would also like to thank my friend, Dr. Katz, and his team who are with us today. Thank you, Dr. Katz. H&H's proposed operating budget for fiscal 2026 totals $1.7 billion, which represent roughly 1.5% of the city's budget. The changes to H&H budget since the release of the fiscal 2026 preliminary plan in January are mostly related to asylum seekers spending and funding for Medicaid. However, the executive plan also includes new funding for medical malpractice contracts and the mental health continuum, both of which we would like to hear more details on from the agency. We will also review H&H's fiscal 2025-2029 capital commitment plan for $2.83 billion. The capital plan includes significant funding for flood mitigation projects at the Kohler, Bellevue, and South Brooklyn hospitals. These upgrades would ensure that hospitals are fully equipped to operate in the event of a natural disaster like Hurricane Sandy. I applaud H&H for recognizing the need to invest in storm-proofing facilities, and I am eager to hear details on this capital projects and the timeline to complete them. In addition, we would like to discuss the council budget response items that were not funded in the executive plan, such as $65 million requests to expand the emergency room at Metropolitan Hospital. the call to baseline $5 million for the mental health continuum, and much more. Lastly, we would like to emphasize the need for H&H to ensure that hospitals have an adequate number of physicians and that those physicians receive H&H's full support at their workplace. The recent Doctors' Council negotiation have highlighted the difficult conditions that physicians face. And it is important that H&H has the right plan in place to ensure physician retention and workplace satisfaction. Before we begin, I'd like to thank the finance staff, Aman Mahadavan, and Floritin Kabore, and legislative staff, Rie Agazarawa, and Joshua Newman for their work preparing this hearing. I would like also to thank my Chief of Staff, Syed Joseph. I will now turn it back to Chair Brennan.
Thank you, Chair Narcisse. Before we get started, I also just want to take a quick moment to thank everyone who makes these hearings happen. It takes a small army of folks in the mighty Finance Division to pull all these hearings together. We are at about the halfway mark of hearings. Especially today, I want to thank Flo and Aman Madhavan. And I want to now turn it over to my committee counsel, Brian Sarfo, who will swear you in, and we can get started.
Good morning. Do you affirm to tell the truth, the whole truth, and nothing but the truth before this committee, and to respond honestly to council member questions? Dr. Katz, Vice President Olberg, Vice President Yang. You may begin.
Doc, just hit the mic.
Good morning, Chair Brennan, Chair Narcisse, and members of the Committee on Finance and Health. I'm Dr. Mitch Katz. I'm the proud president and CEO of New York City Health and Hospitals, and I'm also a primary care doctor. I'm joined by John Olberg, our very capable Chief Finance Officer, and Dr. Patsy Yang, who directs very well our correctional health services. I love your opening. I never thought in terms of that we are only 1.5% of the city's budget. I think that we bring honor to the city for 1.5%, but it also tells you a lot about what the challenges will be, because most of health and hospitals is not New York City tax levy. Most of New York City health and hospitals is state and federal revenue that we receive for the services that we provide. And those revenue sources, as we saw in today's headlines, are very much threatened by the bill that was passed by the House. Overall, that bill could result in hundreds of millions of dollars. I mean, it has so many different provisions that it is not at all easy to calculate how large smack it will be against health and hospitals, because some of the provisions say work requirements which start in 2026. What has happened in other states like Arkansas that have had that is it doesn't result in more people working, it just results in more people falling off the rolls because it's an obstacle, it's forms to fill out. It's not about working, it's about proving that you're working. And if you do not provide sufficient proof that you are working, you get tossed off. It also has provisions about decreasing the state's decreasing the federal share, so the state would have to pay more toward Medicaid, which will likely result in the state having large deficits, and it's likely that they will therefore have to shrink what we get. There are shortenings of the enrollment periods. There are a variety of provisions that will be harmful. The current law also says that if the state continues to provide funding for immigrant health care, that the federal government will cut the amount that the state receives for others. There is a cut of Medicaid for trans care, which we proudly provide, and the cut is not just for trans care for children, but trans care for adults as well. I mean, this bill is as new as this morning's headlines, but it's only getting worse so far. I think we're in a very unusual state All I can promise you is that we will work closely with you, with the executive, with the ONB, and we will put our patients first in terms of protecting them. But there's no way that the system could be the same if we lose hundreds of millions of dollars. I mean, that's we would have to, constrain the system. There's no other way. We are very good at producing revenue, but if it's $300, $400, $500 million, I mean, there's just no way that we could do that without having to have many fewer services. So I apologize about starting on such a somber note, but I felt it's necessary because in some ways the rest of our plan, which is based on, if you will, yesterday's financing, is very good, right? The rest of what I have to present, because it's based on yesterday, we're doing very well. We're going to close fiscal year 25 with a cash balance of $598 million, which is 20 days of cash on hand. It's not what most private systems run at. They usually run at 6 months cash on hand, but for us, it's doing well. We are breaking even. We closed March having produced $167 million more due to patient care revenue. And again, we're not interested in billing patients, but we're very interested in billing insurance companies, and we are, quite aggressive at doing so. Our direct patient care revenue through March is $779 million higher than the previous year. But again, I'll point out that's because the people have a source of insurance. If the people have no source of insurance, there's nobody to bill. And so the increases that the fact that health and hospitals over the last 7.5 years has learned how to successfully bill insurance companies so that the city can get great services for its patients without having to spend its own tax levy will not be able to continue. We were grateful to receive $3.6 million in funding for the mental health continuum. I should also mention one of the other programs that's very much at risk is the Essential Health Plan, which enables people who are undocumented to buy in, right? They're paying their own way to get insurance, but that program is very much in jeopardy. So I feel like, we had a very successful preliminary hearing with all of you, and we're always happy to learn from you, to respond to your questions. And as of yesterday, all of what we said was correct, but depending upon what that, the bill that was passed today by Congress has to go to the Senate. A fellow Brooklynite, is the minority leader there. And we hope that he will be able to, get his Senate colleagues to change that bill. But it's going to be a very difficult road for health and hospitals if there are not substantial changes made in that bill. Thank you.
Thank you, Doc. I really appreciate your candor. I think you're the most honest about what these uncertainties could mean. We've done 7 days of hearings, and no one's ever spoken as honestly as that, and we appreciate that, because that's how we're seeing it too. There's no good answer here. It's every day waking up and waiting for the phone to ring to see what's next. And the fact is, we can't survive without federal grants and federal subsidy in all of our agencies. So appreciate you being honest about that. It's refreshing because we haven't heard that just yet, and we can't stick our heads in the sand about what could come and that we need to be prepared. So we appreciate that, Doc. Also been joined by Council Members Ayala and Moya. I'm going to jump right in so we can get moving. The FEMA COVID funding. So the executive plan included $212.2 million in federal stimulus reimbursements from FEMA in FY25. This is for COVID-related costs incurred during the pandemic. Could you tell us to date how much COVID-related federal reimbursement funding has H&H claimed?
Yes, good morning. Yes, it's been billions of dollars. It's probably somewhere over $1.5 billion in total, and we can get you the exact number there. The 212, and there's an additional 250 million that's still being processed, represents the last amount of FEMA funding.
So how much is left to claim?
So there's this 212 million that's reflected here. There's another, I think, around 230 or so million. We're still working out those final numbers. That's been approved by FEMA. It's been passed from the state to OMB, and it will eventually come over to Health and Hospitals at some point here soon. But in total, it represents the total amount of COVID claiming that we've processed to date, which is, quite an accomplishment. We would have never made it through COVID without those dollars. There was also, as you may recall, there was PRF funding, which was, on maybe another $1.5 billion. So in total, the whole COVID-related expense was somewhere near $3 billion. So for us, for Health and Hospitals, it really, for me, represents the last chapter of COVID. Hopefully we never have to revisit that again. But it does show to me that government can work, right? We stood up these services. The federal government responded, almost immediately when we didn't have any money. We were getting very close to having no money, running out of money. So through the combination of what we call PRF funds and FEMA funds, again, in the neighborhood of $3 billion, and we're at the very end of that process of claiming those dollars.
Okay, so one of the things we've spoken about the past couple of budget cycles is how we're handling the final expiration of COVID dollars, and there were a lot of what have become, crucial programs that became permanent programs, but it was propped up with temporary money. Are you seeing challenges there for how to continue some of these programs that people now rely on that may have been funded by money that's expiring?
Yeah, for us, no. I would say the answer to that, we've lived through, the problems that we were having with the temporary nurses. We found ourselves in really a financial pinch there because we had a lot of temp nurses that were very expensive. But happy to report, we've hired over 3,000 of our own nurses, and we've we've no longer continued the contract with our contract nurses, and we prefer to have our own. So I would say no, we've decanted ourselves off of COVID, I think, very successfully. I think we came out actually a little bit stronger.
I would just add, because I know the grant you mean, from that was a grant where many of the departments had dollars that were used for extensions, but we had spent the money in the period, so we weren't part of the extension.
Got it.
So like my sister department, DOH, MH, they needed to continue to use those dollars, but our share was spent, as John said, on nurses, and so it ended. We're not part of the extension.
Got it. That's great. It's great to hear. The baby box pilot, so the preliminary plan included a new need of $2.6 million in FY26 and a baseline funding of close to $3 million starting in FY27 at Jacoby, Lincoln, Elmhurst, and Kings County for the baby box pilot program. Has the pilot started? And if not, when does H&H plan to start the project, the pilot?
The project is going. It's going at Jacoby, Lincoln, Elmhurst, and Queens. Yes, it's going, and yes, we very much believe in it.
Has the scope of the program changed at all since the preliminary hearing?
No,
Is it at Kings County too?
not right now.
But we're going to get it there?
Yes.
More money, yes. Yeah.
That's a good answer. Correct. Okay. I want to talk about the DPTs, the state-directed payment template application. New York State's share of the ICP payments totals about $57 million. As you may know, the council is seeking a change so that the nearly $57 million reduction would go only into effect if the Medicaid reimbursements were approved or covered by alternate forms of Medicaid funding. So with the state budget now enacted, I guess, after nearly 6 months now that the state has submitted the request to receive the Medicaid funding, what's the status update on the state's DPT request? Has it been approved?
It's not been approved, but they have continued to send questions. So that generally means that they're planning on approving it, because why bother continuing to send us questions about how it would work? But so far, no approval.
Okay. The executive plan includes a one-time $614.3 million allocation for the Medicaid initiative adjustment in FY25. Is this additional Medicaid funding considered a contingency plan if there's further cuts from Washington?
No, the 16 is really, I would say, a cash adjustment, an accounting adjustment. As Mitch had mentioned, we're in the process of waiting approval for the state-directed payment, from CMS for actually this year. And these $600 million was actually in reserve with OMB and HRA to fund the non-federal share of that transaction. And since it looks like it's going to be delayed out of our fiscal year, we're pulling those dollars back. So it's really like a cash transaction. So we'd be very happy if the state-directed plan gets approved, right, by CMS, and then we'll use those dollars again for transfer it back over to OMB and HRA to cover the non-federal share of Medicaid. So it's really just a bridge or an accounting adjustment to get through this year.
In the event of the real doomsday scenario of draconian federal Medicaid cuts, what is OMB saying or the administration telling you as far as a contingency plan? Are they asking you for a plan? Do they have a plan?
Well, I think at this point we're really trying to figure out, what is in the bill. And we spend a lot of time looking at it, as well as everybody else. So we will just have to piece that together, right? We'll have to figure out what really is, the damage. The governor needs to make some very important decisions. We've never seen anything like this. I've been doing Medicaid for almost 30 years, and we've been through some rough times. Obviously, this is one of the worst. But I will say, right, we have good partnerships. You and our delegation, our friends in Albany.
Do you feel supported by City Hall and OMB here? Are they checking in with you?
Well, certainly, yeah, absolutely.
But are they asking you for a plan, or do they have a plan?
I mean, most of what we've been working with them on is advocacy, especially for members of Congress, pointing out how many Medicaid recipients there are in their area. I told you a lot about health and hospitals, but there will be similar problems with other safety net hospitals because they too will get significantly less money, and we know how important hospitals are to communities. So far, we've been trying to put most of our effort into advocacy, into trying to make people understand. I mean, I think one of the fundamental things people miss is that the money for Medicaid doesn't go to the recipient, right? The money goes to hospitals, to doctors, right? So we're trying to build up a constituency to oppose it. If these rather major cuts happen, I have started already looking at administrative decreases. How we would have less administration. You have to be careful because some parts of administration make your operation run better. But part of focusing on patients is saying, that they come first. So what are the things that you're going to do? But I think the approach would have to be a constraining of services. You'd have to look at we would have to, with you and others, look at all of the services we're providing and then figure out, which are the ones that are more essential than others. Keep doing the ones that are most essential, stop doing the ones that we believe in but are not as essential, and hope that in a few years, the world changes and we have additional dollars and grow it back. I don't think there's any magic that's gonna. And I expect that the state will push out most of its cuts. That is to say, that they won't use their surplus, because generally you don't use surplus for one time. As the budget chair, you know that. And I think they'll view these as ongoing cuts, right? And they could easily across, and again, it won't just be government, right? I mean, the state keeps open multiple safety net hospitals in New York City with large annual subsidies. So I think there's going to be a lot of hurt all around.
Okay, I'm going to turn it over to, sorry, we've also been joined by council members Williams, Hudson, and Mamarato. I'm going to turn it over to Chair Narcisse. Thank you, Doc, and your team.
Thank you.
Good morning. It just, I don't even know how to start my questions because I'm processing it. I was hoping that federal level will understand how health is such a key factor in any human being life. So right now, I was hoping that we were gonna get it right, but that's where that hope collides with the reality, and we have to face this. And for the insurances we're talking about in New York City, most of the insurances, as we know, they're all driven by Medicaid. And if we're not getting that, your billing that you're counting on is not gonna be there, because they're gonna have that decrease. This is the reality that we're dealing with. We can have insurances, but if the Medicaid decrease, most of the folks that we're serving, we will not be able to bill. It's unfortunate looking at all this. So, Dr. Katz, we still have to get the question, and we're hoping for the best, even though it's just hard right now. In the council's preliminary budget response, we called for addition of $65 million in capital funding to expand the emergency room at Metropolitan Hospital, which was not included in the executive capital plan. Can you provide a status update on the request? Has there been any conversation between H&H and OMB about this project?
We are talking to OMB, and I think they understand and recognize Councilmember Ayala, who's been such a great supporter of MET in so many ways. The MET Emergency Department, somewhat like the Elmhurst Emergency Department, are both way undersized for the volume of patients that they're currently taking care of. And so you cannot provide the level of confidentiality, the level of infection control, because people are just too close to one another. In the case of MET, we have a specific plan about how we would modernize that ED, and we will keep working with OMB, but we don't yet have approval for that.
Thank you. Can we expect this funding to be added anywhere in adoption? What's the hope?
We'll keep asking with OMB.
Okay. Were there any other new capital projects that you submitted to OMB for funding in fiscal 2026? If yes, can you tell us which projects?
We have a list of, projects in our capital plan that we submit every year. We are, at this point, we did get an acceleration of some dollars from the outer years into the current year, and that'll be useful, but it's mostly to cover what we term as infrastructure needs. I mean, this is really, projects to keep the lights on and, modernize our equipment and make sure that our elevators work and the roof doesn't leak. And we have $1 billion of those needs. So we continue, right, to also, make requests for, certain projects so that they're aware of those. But at this point, we're focusing more on our infrastructure needs as our highest priority.
Can you provide a list to us as well?
Sure, certainly.
Thank you. Recently, there have been complaints regarding the Elmhurst Emergency Room that are similar to those at Metropolitan Emergency Room. Patients in the Elmhurst Emergency Room are experiencing extremely long wait times. The staff does not have the capacity to meet the demand. And it's clear that the emergency room needs to be expanded to meet the healthcare needs of the surrounding community, which you already alerted to. Is H&H aware of the issues with Elmhurst Hospital emergency room? Does H&H share my belief that Elmhurst emergency room needs to be expanded? You spoke about it, but I'm gonna tell you from my own personal experience, back then it was bad. So I went to visit, it was a shame. So I don't know how we're gonna get this done. Is this part of the list of the capital?
Yes, but the list that John refers is a $2 billion list. And our facilities are, way beyond their projected life. We just keep things going because the people need our services, and we're going to keep going as long as we can. To your point, Chair, the average volume at Elmhurst is 3 times the size that the ED was built for. You build an ED, you know what the size is. It's meant to handle a certain number of patients per day, and we handle 3 times that amount at Elmhurst. And in some ways, it's a nice thing. The community deeply trusts Elmhurst. People keep going to Elmhurst.
Keep coming.
Right.
Yeah.
There are other hospitals that people could go to, and they go to Elmhurst because they feel safe at Elmhurst. And they feel cared for, and that they're not made to feel bad for being poor. But Elmhurst, in some ways, is a more challenging problem than Met, because as you know, the plot of land, it's kind of landlocked. It's got streets, and you gave me an idea about
I give you a street, right? Backstory.
But which I think is a very interesting idea, but that's part of our struggle has been, well, where would we build it, right? And you have to build it somewhere where you're still running what you have, right? We can't close half of Elmhurst and knock it down and build something new, right? We got to keep doing what we're doing and build something new.
Yeah, but I have an imagination how we can be done since I've been in the ER. So that's the reason I was talking about Baxter Street. Since we have Chair for Transportation with us, I think we need to make a plan for that, and I have my vision, and we can talk about this offline, because I think we can be still functioning, because the ramp where the ambulance come, so that's where you're gonna build that. I'm not an engineer, but we have ideas.
Oh, I love the idea.
So
Brilliant.
we can use that. So thank you. Does H&H believe that this capital project can be funded in a short term? In the near future, very short?
Not without help from OMB. OMB would have to, and I know, and again, this is not to put pressure on them. They have a lot of needs that the city has, and I'm not expert on, how large their capital budget is to disperse, but they know we need it, and I think they know, that your committee has discussed these issues and sees them as critical, and Met and Elmhurst EDs are at the top of our list. And I say that also recognizing a lot of what we use capital for are things like the air handler goes down. Right? Well, if the air handler goes down, you can't run a hospital. So we wind up a lot of what people would call capital dollars. In the end, we wind up spending on coolers and boilers and elevators.
I know.
Because again, in the absence of other things, what can you do? You can't run a hospital without an air cooler. You can't run it without a boiler. And so, it's not as if we can take all the capital dollars and use them to build new things. We have to keep the existing things going. And again, with space as well, that's always the challenge of a hospital, is you can't close it to build something new. And so you always are building on a working hospital, which makes it more expensive always, and just physically more challenging.
So you know how much that will cost to get an emergency room at the Elmhurst Hospital?
We've always talked it with Elmhurst as a multi-phasic plan, so I don't know if we have
I don't think we have
an
the,
estimate of just the ED.
yeah, not yet.
Right, because again, the whole question with Elmhurst is where.
Exactly.
You got to knock down something, or Baxter Street. I'm going to go back and look at my maps as soon as I'm done with this meeting, because I like that idea.
It can be an open street. We have ideas, but I'm going to continue that with the transportation
I'm
chair.
so glad you have that close connection with the transportation chair, although I think she's sinking into her seat.
Council budget response, we are talking about the one that not funded in the executive plan. In the council preliminary budget response, we called on the administration to add $6.3 million in the executive budget to create 250 new residential treatment beds for Rikers inmates. Why was this funding not included in the executive plan?
OMB, and we are continuing to talk about it. We are hoping to get approval from City Council for the Just Home Project, which is supportive housing for this population. But the additional beds, we do not yet have funding for.
Okay. We called for $5.3 million to be allocated for the purchase of 2 new CT scanners and an interventional radiology NGO single plane imaging system for Bellevue Hospital. Why was this funding not included in the executive plan?
Again, with all of these, we're negotiating with OMB to see what they can support. I would say that we were able, through the funding that we received from Mount Sinai, to enable us to take care of their patients who were previously cared for at Beth Israel. We were able to get funding for an additional CT scanner at Bellevue.
Okay. The council budget response called for the addition of $5 million to allow H&H to hire a maternal health-focused psychologist in each H&H maternity department. If this funding is included in the adopted budget, in which ways could this proposal be implemented, and which hospitals are currently in urgent need of mental health support for new mothers and their families?
I think all the hospitals would benefit from having additional mental health personnel. I think part of the misunderstanding about maternal mortality is how many of the deaths occur long after the delivery, and that there is a tremendous need to support new moms in that first year. So if the funding is provided, we would expand. We certainly do our best with existing mental health personnel, and we try to prioritize the needs of new mothers because we see it as, such an important issue.
The council budget response also called for $4.5 million to hire 60 new maternal health peer specialists to staff the city's multi-agency mental health and crisis response teams in coordination with H&H. Has there been any conversation between H&H and OMB regarding this request?
I know OMB understands the crisis about maternal mortality, but we have not yet gotten a funding amount for it.
Okay, in both the fiscal 2025 and fiscal 2026 council preliminary budget response, we called for the addition of $300,000 for the creation of the pilot women's concussion clinic, which was not added in the executive budget. The clinic would provide trauma-informed care to domestic violence survivors through H&H, or to be contracted out. What are the agency's thoughts on the proposal, and how would you implement if the funding is made available?
Well, we've worked closely with our sister department to end gender-based violence, and King's, very close to your district, has a sort of state-of-the-art program that really focuses on the risks of suffocation and head trauma. So if if this gets funded, we would absolutely augment that program at King's and look at that as a pilot for other hospitals as well.
In the council's response to the preliminary budget, we urged the administration to create a new outpatient building at Lincoln Hospital, a project you indicated was a capital need for the system during our fiscal 2026 preliminary budget hearing. Do you have an estimate of the full project cost? Why was this funding not included in the executive capital plan? Has there been any discussion between H&H and ONB on funding this project?
Well, at least on this one, we have the space right across the street from Lincoln, and we would not have to knock anything down. So that's the good part. The bad part is that the price tag is $600 million, and at the moment, we don't have a funding source for that.
H&H overall headcount has increased by 2,128 positions. When comparing the third quarter of fiscal 2025 with the fourth quarter of fiscal 2024, the largest increase is in registered nurses. I'm not complaining there, with 609 additional budgeting positions. There has also been a decrease of 9 physicians positions. What is H&H's current overall vacancy rate?
So yes, we so appreciate you as the highest ranking nurse in the city. And we have...
I don't know about all that. I'm not doing hands-on anymore.
A nurse is a nurse. It's a spirit, not a procedure. We're very pleased to have our own nurses rather than registry nurses, and I thank the City Council for advocating for fair and equitable wages for nurses, because without that, we could not have possibly done this. And we worked closely with OMB, and they helped us to get a fair contract, with the result that we now are able to hire our own nurses. The reason you see a decrease in the physicians is only that they have moved from the city line to the Pagney line, because it's preferred by most of the doctors. We generally give people at some of the hospitals like King's a choice. They can be on either line, right? We're anxious to recruit doctors, but there's no absolute decrease. Overall, we are taking care of more people than we have taken care of in recent history, and we have more doctors and nurses than we ever have.
I appreciate that. Do you anticipate any major increases or decreases for any of the headcount categories in the fourth quarter of fiscal 2025? What about in fiscal 2026?
Not in the fourth quarter of 2025. I think what happens beyond that is going to depend on what that final Medicaid budget does, and how the state handles how much of the losses they need to push down to the counties.
What efforts is H&H making to ensure that the system retains a sufficient number of physicians?
We recruit hard. Our salaries are comparable to
Nice to hear.
other safety net systems. We're not comparable to the private sector.
Okay.
But we are blessed with many physicians who remember taking their immigrant parents to health and hospitals and made a commitment that they would, give back by working at health and hospitals. Generally, as a rule of thumb, my thing is that people will work for 80% of the salary. The 20% can be mission, but they won't work for 40% of the salary. So you have to be in the ballpark. We will never be the highest payer, and I tell people when I recruit, if you want the highest salary, you're the wrong person for health and hospitals. Don't come work to us because you want the highest salary. That's not who we are. Come work for us because you'll have a comparable salary, and you'll go to bed every night knowing that you were taking care of people who really needed you. And I think that has to be the health and hospital transaction.
Yeah. I got it because that's why they didn't pay me much either.
No. we're
passion.
We're an equal underpayer.
Yeah, but I enjoy it. Like you said, it's a passion, it's a calling, but we have to pay the bill too. How is H&H working to support its physician in relation to the demanding working conditions they face?
Yeah, it's a fascinating question because in the 40 years I've practiced medicine, the world has changed, right? And 40 years ago, it was shut up and do your job. Mm-hmm. You know, doctors shouldn't be emotional. I remember being told, you know, when I was crying about a patient I knew quite well who was dying of cancer, I remember being told by the senior doctor that I was being too emotional. Mm-hmm. Right, I mean, that was the idea, right? The idea was no emotion, do your job, come to work, you're sick, come to work, right? And we now recognize why that's inappropriate.
Yeah.
And, you know, it's taken a while for the systems to, you know, figure out, you know, how do we help people in very stressful jobs, and what is the right answer? And some of the first answers were probably wrong. A lot of the first answers were, okay, well, we should have yoga classes and meditation, and those things are good, but it doesn't help if you make the job stressful and then say, okay, for the next hour we're going to do yoga, and then you go back to something really stressful. I think people realize that's not the answer. The answer is you have to make the whole job doable, right? And then if the person wants to go to yoga after work, they can go to yoga. But it isn't about taking breaks from things that are stressful. It's about making the job doable. And you know this from, you know, doctors have a lot of responsibilities, right? All the orders legally have to always be signed by doctors, and it puts burden on doctors to do things that often really are not even doctor jobs, right? As a primary care doctor, I have to sign off every request for durable medical equipment for patients in the outpatient. Mm-hmm. Why? Mm-hmm. All of these patients have a physical therapist. They have a home nurse, mm-hmm. right? Mm-hmm. But the rules say mm-hmm. that a physician must sign off. And so we put huge requirements on doctors to do things that are often not medical, and it causes a lot of stress to doctors.
True that. So why can't the physical therapist do that and the doctor write it in the note and the physical therapy can actually send the patient home with that?
Because the regs don't allow it. But
anyway, that's another story.
You are correct about what would be
ideal.
Sensible. Same. Yeah. One of the ones I always found fascinating is nutrition notes have to be signed off by the doctor. Mm-hmm. Right? You know how little most doctors know about nutrition. Yeah. Right. So what does it mean that a PhD level nutritionist figures mm-hmm. out the calorie counts and the correct diet, and then I sign off on it? Mm-hmm.
It should be enough to write it on the note. Okay, cancer screening and support continues to be a pressing issue for the system and desperately needs more funding. In one of our recent conversations with our team, it was stated that the system was looking for a request of $500,000 for the addition of 2 nurse practitioners to serve as navigators for high-risk cancer patients. We know cancer is hitting home federal level everywhere. Has this request been made? If yes, what is the status of this request to OMB?
We've requested it. OMB hasn't yet determined if they can or cannot fund it, but we certainly see it as pressing. I think the field recognizes that unless you have cancer navigation, mm-hmm. People do not follow through. It's just too difficult. It's emotionally stressful for people. People are afraid of the results. Some of the things like colonoscopy are fairly difficult procedures to get done because of the requirements of taking medications to flush the system ahead of time. Navigation makes a huge difference. So we will keep working with our OMB colleagues to see if they're able to fund it.
Yeah. Can you please describe the available services for cancer patients that H&H cares for, including prevention care?
Certainly. So, the largest amount of cancer prevention care occurs in primary care, and we do very well, much better than other systems in New York City in primary care, because we are much more a primary care system. We all receive, when I was in clinic last night, for every single patient, my Epic chart tells me when she is due for a pap smear, who's due for a mammogram, who needs a Pneumovax, right? All the things are on the left-hand corner. I think and we do very well. I think where the challenge comes in is the navigation that's required. Let's say a woman has the mammogram. Generally, we're very successful at that. Where it's more difficult is the mammogram has an abnormality. Now, the process is not simple, right? To go for the mammogram, pretty simple. We have people who call, don't forget your appointment, Tuesday, 10:30, people come. Where we run into problems is it's an abnormality, we're not sure. Next step is a diagnostic mammogram, then you probably need an ultrasound, then you may need a stereotypic biopsy, right, and multiple steps. Many of those steps can't happen if you're at a clinic. They can only happen at a hospital. Some things have to be guided by ultrasound. And so that's really where the navigation is needed. Same thing with colon cancer screening. Very high rates of people doing the test for blood in the stool. We do super well. Getting people who are positive on that test to do the correct procedure prior to the colonoscopy. If you don't flush the system, then the colonoscopy is not accurate. Making sure they come. It's something people don't want to. You have to have a ride to get home because of the medication. One of my own patients had an appointment. His ride fell out, right? And so he couldn't do it, right? I mean, if I needed the test and my ride didn't work, I would be able to take an Uber, I would take a bicycle, but that wasn't available. He didn't have the money for those other things. So that's where the navigation is so critical.
And not only that, too, people in denial when they first learn they have cancer.
Yes.
So they need that support to walk them through, or you don't see them, they go and pray.
Right.
Pray is good, but the doctor's follow-up is good. Yeah.
Works better with treatment.
Yeah. What is the most recurring type of cancer, and what demographic constitutes most of the H&H cancer patients?
Well, because of who we take care of, almost, we have a very high proportion of Black and brown patients in all of health and hospitals. So that's what our data reflects is, their rates of cancer, which are very high.
Which cancer is very high?
Well, so the ones that are most common in us, and I can't honestly say I could tell you which is the highest. It's colorectal, breast, and prostate that run the highest in general.
Yeah.
Lung, too.
Lungs.
Yeah.
And there is an increase in Black male early age that getting diagnostic tests done.
We've dropped the screening ages because of those increases.
That's right.
Yeah.
Instead of 45, you have to bring them earlier.
Yeah, exactly.
Okay. What age?
44 is when we start talking
44?
about mammograms. 45 is when we talk about colon cancer, but we'll go even younger if there's a family history.
Much younger now, because I have some that I'm hearing from doctors in the under 30s.
Yeah, me too.
That's scary for Black male.
Very scary.
Yes, we need to do more. How can the council, I know it's not too sexy to talk about health, right? How can the council further advocate for the creation of new cancer-related programs or services within the system?
Well, I think part of what we've tried to do is by doing the navigation, we think that we also can save some money because especially for higher level procedures, if someone doesn't show, You're paying for the doctor and the technologist, but there's no revenue because the person didn't show. So we think, using navigation actually can help us to be more efficient. But beyond that, we appreciate the City Council's support of these programs and recognition that many of our patients need a little extra help, right? They often don't have the same level of family support that people who are financially better off have.
Yes. Yeah. In the executive commitment plan, $32 million was transferred from the Correctional Health Outpost units holding code to fund the Woodhull unit. The total capital funding for the Woodhull unit is now $306.8 million. During our preliminary budget hearing, HND stated that the timeline for the Woodhull unit's construction was delayed beyond the original estimated completion date of 2027. HNH also stated that you were still waiting for the feedback on the design from DDC, after which you would be able to begin the contracting process. Can you please provide an update on the construction process and timelines for Woodhull unit?
Dr. Yang will explain.
Hi, thank you. The hope is still to target 2027 for the completion of construction for the units at North Central Bronx and Woodhull. Design is still pending finalization, so we are still waiting for the Department of Correction and the State Commission on Correction to give us feedback. It is getting tight, but we are still hoping for that.
Okay. In the fiscal 2025-2029 executive commitment plan, the total funding for the North Central Bronx Outpost unit remains unchanged at $265.6 million, $69.6 million, compared to the preliminary commitment plan. However, about $135 million of the funding was rolled from fiscal 2025 and fiscal 2026 into fiscal 2027. Why was the funding rolled into fiscal 2027? Is it due to a delay in the construction timeline?
My understanding is that the rolling of the funds is aligned with our targeted of 2027 completion of the construction. It's sort of moving it from the savings account to the checking account, so we can actually start that work.
Okay, I'm gonna do a last question so I can pass it back to my colleagues. At the preliminary budget hearing, you stated that the timeline for the North Central Bronx Outpost unit was delayed beyond the original estimated completion date of 2027 for the same reason as the Woodhull unit. What is the new timeline for the completion? Do you believe that the project will be completed on time?
It remains still 2027, end of 2027 completion for both units.
Both? Okay. So pass it back to Chair.
Thank you, Chair Narcisse. We've been joined by Councilmember Sanchez on Zoom. Now we're going to start with the Majority Whip, Brooks Powers, for her questions, followed by Councilmember Lewis.
Thank you, chairs, and hello, Dr. Katz, and to your team. I just want to thank you and the administration for your partnership, particularly on the effort for the trauma facility in Far Rockaway. And so while we regularly talk, I just wanted to ask some of the questions for the record, particularly just wanting to hear from you, Dr. Katz, on how Health and Hospitals has engaged with the New York State Department of Health on the certification of the Far Rockaway Trauma Center.
Well, I just want to commend you, Majority Whip, for an incredibly inclusive process with the community and community leaders, elected leaders, nonprofits on Rockaway Trauma Center, and how we've been at these meetings and the participants have been very articulate about the need for a trauma center, and for everybody to understand the unfairness within Manhattan. It's probably be 5 minutes to a trauma center. If you were going to have a emergency on Far Rockaway, it's 45 minutes with a police escort. And we know that because of the tragic shooting of a police officer. But of course, it's not just police officers, it's people who live there who have to travel to Jamaica Hospital. And there's just no way to get there quickly. As our chief nurse would tell us, right, our chair nurse would tell us, minutes matter with trauma. When you're bleeding, you got to stop the bleeding. So we have worked with the state, and they have indicated that they would be supportive of a trauma center on Rockaway. They would be enable us to staff that center at the level of a level 1 or a level 2 trauma center. They will not certify level 1 or level 2 unless it's a full hospital, but they will certify a level 3 trauma center if it's like a micro hospital, it's licensed as a hospital. And they have shown a willingness to work with us because they recognize how geographically isolated Rockaway is.
Thank you for that. And how has Health and Hospitals advocated for the advancement of this critical proposal, including the $300,000 needed to complete the NYCHA land transfer for the trauma center site?
Yeah, well, under your leadership, we're continuing to work with the executive, and we have a meeting set up, as you know, on the 29th with a variety of local leaders to access the $300,000. The mayor has been very supportive of that plot of land being used for a trauma center. It's a piece of land currently owned by NYCHA, but there is no plan to build on that land. So we're not taking away housing. There's no plan for it. And it's an ideal site for a trauma center because it's large, it doesn't have any residential property close to it, and it's very close to the A stop.
Dr. Katz, I would love to thank you, the mayor, as well as my colleagues in the council for all of the work thus far. I know we have a long way to go. Chairs, I just want to ask one more question, which is focusing on the Far Rockaway Primary Care Center, which we got to break ground on a couple of months ago. The executive plan includes $28 million for the Far Rockaway Primary Care Center. This new comprehensive community health center will expand access to primary care, women's health, dental, vision, and mental health services for the Far Rockaway community. The facility is expected to open in calendar year 2027. On February 25th, 2025, the administration announced that the construction of this facility was underway. Has the construction timeline for this center changed at all since our last budget hearing?
No, we're on time, on budget.
Sounds great. Thank you,
Thank
Dr.
you.
Katz.
We have questions, Councilmember Lewis, followed by Salam.
Thank you, chairs. I like that on time, on budget.
That's right.
That's good. Hi, how are you, Dr. Katz? So good
Good
to
morning.
see you and your team. I'm a big fan.
Thank you.
I used to work at Mount Sinai Hospital, so your name rings bells all over the place. I have 4 quick questions, so I'm gonna try to get them all out, and then from there you can answer them. All right, so is NYC Health and Hospitals currently meeting adequate staffing levels at Kings County Hospital? And if not, how does the agency plan to rapidly scale staffing to absorb a possible patient surge resulting from SUNY Downstate's curtailment? So we know that SUNY Downstate asked for $1 billion in funding, that they didn't get that. They end up getting $750 million from the governor, so there's a shortfall of $250 million. So I wanted to know, is Health and Hospitals currently meeting current staffing levels to accommodate for whatever may happen at Downstate? With H&H system currently projecting $598 million cash on hand, how would the potential displacement of services from SUNY Downstate affect Kings County's operational and financial trajectory? And these 2 questions are about the doula initiative. I know it falls under DOHMH, but my 2 quick questions about this is, have there been any administrative or overhead costs associated with incorporating doulas, such as credentialing, facility upgrades, or staff's training? And if so, how is H&H tracking and budgeting for these costs? And how is H&H prioritizing the renovation of existing facilities and the strategic allocation of personnel in its capital and staffing plans to support the long-term success of doula-based interventions?
Very good. Well, thank you for your questions and for your support. So right now, and this is a change in health and hospitals from 7.5 years ago, we staff for our census. That didn't used to be the case. It used to be, there might be, and again, our chair can talk about this, there might have been 2 nurses and 10 patients, 2 nurses and 12 patients, 2 nurses and 15 patients. We staff for our census now, and we staff according to the state ratios. Occasionally, we do, in honesty, miss it if we have a lot of sick outs. Sick outs are hard to prepare for because the schedule says you have 4 nurses, but what happens if you only have 2 nurses?
Right.
Because 2 are unexpectedly out sick. King's has already absorbed some of what used to be at University Hospital because they've closed several of their lines of service. So we are much fuller because of that, but we will keep staffing up depending upon what happens to that hospital. And again, before there are any of drastic Medicaid cuts, we can generally fund ourselves increased volume if it's just the volume. If we're not building anything, if we're generally insurance will pay us our costs. Our costs are much lower than Mount Sinai, much lower than NYU because we don't pay people what they pay them. So we can generally make it work on Medicaid. But obviously if there are a lot of people who lose insurance coverage, then we'll have the same expense because losing Medicaid doesn't make you healthier. In fact, it makes you sicker. So the same number of people will come, but now there'll be no paying source. So that would take us to a different area. I'm a fan of doulas. I think that they make a difference for a lot of women. We have done training. We have a training budget, so I don't consider that a separate expense. We don't track it. We should be training on those things that are important to train for. We have been blessed via the Brooklyn Borough President. He has put all of his dollars to renovations at King's Woodhall and at South Brooklyn. And we think having low-tech areas for women who are having normal vaginal deliveries is a very positive step, and we want more beautiful and also just sort of less institutional spaces. And the money he's given us will allow us to create these birthing centers.
And it's good to hear you already have money in the budget for extended.
Thanks to him.
Thank you. Thank you, Chair.
Thank you.
Okay, we have questions from Councilmember Salam, followed by Ressler.
Thank you for your testimony and good morning.
Good morning.
On budget cuts and staffing at Harlem Hospital specifically, the fiscal year 2026 executive plan reduces health and hospitals budget by over $1.4 billion, nearly a 45% cut compared to the fiscal year adopted budget. How will these cuts affect patient care services and staffing at Harlem Hospital specifically? And are there any planned reductions in staff or service for Harlem that the council should be aware of? And also, what safeguards are in place to ensure Harlem residents do not experience diminished levels of service?
Yeah, I think Harlem has been doing super well. I think George LeConte is an excellent CEO for Harlem Hospital, and we have a very long-standing Chief Medical Officer, Dr. Maurice Wright. We have no planned cuts. It's always at this hearing a little bit challenging because the slice of the budget that you see is the city levy. The city levy, as we talked about at the beginning, is only 1.5% of our actual budget. And so a lot of the movements just are about cash flow and which year the expense is going to come in. Our overall budget is $13.8 Are we 3?
Yeah, 3.
$13.3 billion. So most of, the work that happens, at Harlem, we are, funding through patient revenue. And one of the services at Harlem that I'm most proud of, and I think you will see tremendous growth, is we have a very nice collaboration now with the Hospital for Special Surgery, where they're sending their doctors to Harlem to do surgeries, because as you know, people do not like to leave the village of Harlem, and do not want, even though, for joint replacements, many people choose to go to HHS because of their extensive experience. And now through this collaboration that's headed by an African-American orthopedist who sees this as his life mission, it's wonderful to see that the patients at Harlem are getting an HHS experience at Harlem. And I think that's what we should aim for, everywhere.
Thank you. Lastly, on the capital projects and infrastructure upgrades, the executive capital plan does not include upgrades for Harlem Hospital. Meanwhile, Bellevue, Kohler, and Woodhull are receiving significant capital investments for flood mitigation and infrastructure. Can you tell us why Harlem Hospital is excluded from the major capital upgrades in this plan, and what infrastructure risks exist at Harlem Hospital, especially given its location and age? And lastly, will H&H commit to a feasibility study for flood protection or energy resilience upgrades at Harlem Hospital?
Right. So the capital needs of Harlem are on our $2 billion list. So we struggle, right? I mean, we have $2 billion of infrastructure needs. We know that the city is not going to be able to support all of that in any one year. Harlem, there was a major issue that I was involved in, which was the leaking roof, and we were able to deal with that. I'm not aware, and your question will make me look back. I'm not aware that we have a flood risk so much at Harlem. I'm trying to think about the area around it. Obviously, the flood mitigations at Met and Bellevue are being paid for by federal FEMA dollars that were given to us after Superstorm Sandy. So, I mean, sadly, our history as a country is we wait for the disaster, and after the disaster, we give you a mitigation, right? It would be wiser to do mitigations before you had the disaster, but that's not generally how it works, right? We got a brand new South Brooklyn Health Hospital. Why? And it's wonderful that we have it, because the Superstorm Sandy took out the old hospital. Right, so we will continue to prioritize Harlem. It's a very much appreciated hospital in that community. It's well loved, and we will continue to watch over it.
And just in terms of that, chairs, if you will, about the energy resilience upgrades.
Yeah, it's not an area I know much about.
No, I think, we keep close, touch with Harlem, and it is reaching the point where like a pipe will break, right? And then that affects operations, which then, affects the budget. But I think energy resiliency is something that we're looking at across health and hospitals. If we become more energy efficient, right, we'll make an investment like a better air conditioning system, or better heating and ventilation system that ultimately, will save us money. But it's finding that initial capital dollars so we can make that investment is where we struggle. But we try every day, to find, capital dollars within our budget, and put those dollars to the best use we can.
Thank you.
Thank you.
Okay, we've been joined by Councilmember Osei, and now we have questions from Councilmember Ressler.
Thank you so much, Dr. Katz and team. I don't believe that I have ever seen a more devastating bill pass the House of Representatives for the people of New York City than what the Republicans did this morning. Could you share an estimate with us on the loss of Medicaid funding to New York?
To New York, well, I'll tell you what I know about health and hospitals, right? So health and hospitals, we're in the hundreds of millions of dollars, right?
Well,
I mean,
the reason I
more
wanted
than
to just-
300 million.
I apologize for interrupting. I just wanted to take a somewhat broader perspective. You know, it's been reported that we're talking about 13 plus
Right.
billion dollars in cuts to Medicaid funding statewide.
Statewide.
Is that consistent with what
Yeah,
you
John
understand?
will answer.
Yeah, the governor put out a set of numbers.
13 and a half,
13 and
right?
a half, and I think,
And that-
yep.
There were some changes this morning that may have made
Worsening.
things even worse. So 13, 14, $15 billion in cuts to Medicaid. And which will lead to hospitals potentially closing, gutting service areas, nursing homes closing, tens of thousands of healthcare workers being laid off, millions of New Yorkers losing their health care, thousands of people dying unnecessarily, right? I can't be any more alarmist in the language that I'm using because of just how devastating this legislation would be for our communities. But what we all know is that when more people lose their health care coverage, they depend on health and hospitals, right? So in a world in which more New Yorkers are losing access to the essential plan, more New Yorkers are losing access to Medicaid, more New Yorkers are uninsured, you will be losing hundreds of millions of dollars in direct funding and at the same time be expected to serve more New Yorkers. Is that the right expectation?
You have it right. I don't see it as an alarmist. I think that's an accurate portrayal.
And could you describe the impacts to health and hospitals directly? Last time you were here with Chair Narcisse, we asked about are hospital closures on the table, and you said you didn't believe so, but that you might need to close service areas. Have you started specific contingency planning for what service areas would be lost if this horrific, draconian, devastating, catastrophic legislation actually gets signed into law by President Trump?
So far, most of our effort, we've been on advocacy, right? We've been working 24 hours, 7 days a week, trying to convince people to oppose the bill. And that seems like the right thing for this moment. I think whatever the final bill is, John will be in charge of figuring out, what is the cut to us. And part of what's going to be difficult is that it's going to be a secondary answer because it's going to depend on how much of the cut to the state does the state absorb versus push down, right? So we won't know, even when the bill is passed,
right.
I won't know the number because I won't know how the state will deal with it.
Right. The state could cut billions of dollars for education and public safety and public health and all of these other areas that might protect that Medicaid and essential plan funding, but it will be devastating to our communities in lots of other ways. So there's a series of horrific choices that we have before us if this bill comes to fruition.
Absolutely.
But so you think it's too early to contingency plan and understand at Coney Island Hospital, at North Central Bronx, at Woodhull, what are the direct impacts? You look at the hospitals with low occupancy rates on the inpatient side. You look at hospitals that have service lines that have low utilization or that are costing you more than are generating revenue. You're looking at all of this stuff. Are you able to paint a picture for just what this means for New York City? And you said I'm not being an alarmist.
I agree.
I'm being total. I mean, this is the very tragic reality that we are hurtling toward. It's important for New Yorkers to understand what the impacts are. Right. These are not imaginary things. These are cuts that are going to lead to more people suffering and dying, and we should understand it, right? So could you give us any, I'm pushing you on this because I think it's important for New Yorkers to know this will have direct impacts at Harlem Hospital, at Woodhull Hospital, in our communities. Can you lay out for us, or do you have a timeline for when you can lay out for us what that horrific contingency planning does look like?
Sure. Well, I can only tell you the principles of how I intend to do it, and because I can't really plan without a number, right? I have to have a number of what I'm planning for.
Fair.
But I think I can have principles of how I would go about dealing with a cut as devastating as this one. So to the first part of your question, the health and hospitals that I came to had a lot of empty hospitals, a lot of services that were losing large amounts of money. That is not today's reality. Today's reality.
No, I just want to say, at the time, health in hospitals was perceived as the single greatest threat, risk, vulnerability to the city budget.
Right.
And we no longer talk about that. It's such a distant memory that people don't even remember it because of your leadership of the institution.
Right. So we now are so successful at billing insurance, not patients. We're not interested in billing patients. We're interested in billing insurance. I don't start by saying, I have a, poorly performing low volume service that's costing me more, because I've been working on it and I do every day. I hear this practice is under, like today I was looking at a practice where I had to say, I want this doctor to work over here instead of here because there'll be more patients over here, not enough volume over here. So there just isn't that reality anymore. So then what I would say is, so the principle, we will stay a system that provides a single standard to everybody, because I feel that's what distinguishes us. If we weren't that, then we would be just like every other system. We would just be looking for money as the way to figure out what to cut.
Can I ask 2 more questions? Yeah, thank you. I'm sorry.
So we will keep, so if you take my assumptions, then it says that what you have to do is you have to curtail services. And probably the services you would want to curtail are probably specialty services. So because you have to maintain emergency, right? Because life and limb, and you want to maintain primary care because that's the most cost effective.
But aren't some of those specialty services revenue generating?
It turns out that because they are so much more expensive to do, I would say, if you had to cut something.
Yeah, no, I'm not.
That's where, because you just pay more for specialty services. And again, if you're trying to make a horrible system, a horrible change work, you got to say, what do you prioritize? And I don't see how you say there's going to be less emergency services, because that's where people will bleed to death. I don't think you want to say less primary care.
No, absolutely not. I know that's your priority.
If you say those 2 things, then
what's left?
What's left?
Ambulatory care, outpatient care,
specialty care.
Right, specialty
care. So does the person, just again, because you asked, people see a cardiologist. Does everybody see a cardiologist in the world? No. If you're poor, you see your primary care doctor. If is your primary care doctor as good as a cardiologist if you have a cardiac problem? No. Will he or she do okay? That's the kind of thing that I imagine, is that we're saying, yes, we have a primary care slot. You want to see a specialist? I understand that. I'm sorry, I don't have a specialist for you to see.
So before I get in trouble with the chairs, I just want to try to briefly touch on a couple things. I do appreciate that answer. I do hope that you'd be open to planning and conversation with the Hospitals Committee and the Finance Committee and other interested council members to understand the impacts in advance, so that we can try to make sure that New Yorkers know what's coming if this horrible bill comes to fruition, and the community, of course. We represent the community as the City Council very proudly. The other 2 things I just wanted to touch on. One, I'm frightened by the restrictions on Medicaid access for documented green card holding immigrants. Could you speak to what percentage of the H&H patient population is foreign-born?
Oh, is foreign-born very high? I don't know that, of course we don't.
You don't track immigration status, thankfully. But I wondered if you could track just who's an immigrant.
I would think that we're at 60 to 70%.
60 to 70%. Yeah. Right? And that's not to say that every immigrant isn't a citizen. It's just to say, disproportionately, when we're unable to provide Medicaid to documented green card holding immigrants, it will have a catastrophic consequence on H&H and the need to reduce even more of those specialty services. Second and last is, could you just help me? My understanding is that over the last 10 plus years, we've seen a shift at the wealthier voluntary hospitals where they serve more Medicaid patients than they used to. And I won't ask you to explain why that's happened, but could you just help me understand. Doesn't this mean that the voluntaries have just as much skin in this game as safety net hospitals, that this would be devastating, maybe not just as much, that's probably too far, but that have significant skin in this game, and that this should be a existential threat to their business model if these cuts come to fruition for New York City voluntary hospitals as well?
Yes, well, it's easy to explain why.
Okay,
The reason
thank you.
why is because of EMTALA. EMTALA means that an emergency room cannot deny you care in an emergency, and the city's ambulances go generally to the nearest hospital. So if you are somebody on Medicaid, right, and you have an emergency, you're going to go to the nearest hospital. More people have Medicaid than ever before, and so the other private nonprofits are doing more Medicaid. The big difference, and this was brought home to me by one of my own patients, she called me to say that she had had an accident. She was cared for by one of the great private hospitals of New York City. She has Medicaid. And they gave her, as her discharge instructions, they said, please follow up with an orthopedist. They gave her 3 names. She called me to say, I called all 3 practices, but they said they wouldn't see me. I don't understand it.
Right.
The emergency department told me that I had to be seen in a week, and they gave me these 3 names.
Right.
Right? And the story perfectly explains the situation. There's no outpatient care
Right.
for Medicaid.
Right.
The outpatient care is all with us.
But with the emergency rooms and inpatient
But in the
right?
emergency room and then in the hospital, if
Right.
people need to be Medicaid
To
is
increase their
covered.
occupancy rates, they've served more Medicaid patients
Right.
in their
And
inpatient.
those patients will still come to the private hospitals.
Right.
And they will still have to serve them under EMTALA. And so they will have quite large losses now because they will not get paid.
Well, we all know about the stories of the voluntary hospitals that send people down the block to the H&H facilities when they don't want to serve the people that lack insurance. And we are hurtling toward a reality where hundreds of thousands, if not 1 million more New Yorkers are going to be in exactly that situation. And it's going to be on your doorstep to find a way to provide care to all of these people. And we might again be in a situation where H&H becomes a big vulnerability for the city budget because of these dramatic cuts that we've seen out of Washington.
Councilmember.
I'm done. I'm sorry. Thank you for the time.
Thank you. I have a question from Councilmember Sanchez. Midwives at North Central, Bronx, and Jacoby have been working under an expired contract for nearly 2 years. I believe these are NISNA nurses. I understand that these midwives are gearing up to go on strike, which we know is always a last resort. Could you talk about what H&H's role is in ensuring negotiations move forward?
Yeah, I'm on it. So the particular nurse midwives who are phenomenal, NCB, Jacoby has an amazing group of midwives, well known throughout the city, one of our most successful midwifery services. They are employees of PAGNI, not directly of the city, but now that the issue has been brought to me, I am working with PAGNI, and we believe that what my investigation showed is that there was an offer made by PAGNI. Negotiations are always I offer you, then you respond, and then I offer you, and you respond. So the last offer was by PAGNI. I'm gonna, I want to urge, NISNA and to respond, because that's how you ultimately resolve contracts, right? You don't have to agree with the last offer that was made by the employer, but part of, a union leader once taught me this, the importance is not to disagree, the importance is ultimately to agree. So I hope that I can convince NISNA to make now a counteroffer to the offer that's been made. They don't have to accept the offer that's made. They can make a counteroffer and get the negotiations back on track. It's not unusual. The city council helped me on the doctor issue, right? Similar kind of issue, and we resolved it. And there was a vote to strike, and we resolved it. So usually the problem is people need to negotiate. They need to. It's not sufficient to say, it isn't right. Those midwives are working way below wage, but part of that is because the city midwives have gotten a raise and they're still on 2 years ago's rates. Once they resolve the contract, they will get back pay, but it makes their current pay look particularly awful and makes it hard to keep people. So it seems like my job here, as with the doctors, is you got to negotiate to both sides, right? It's got to be resolved. We're not going to live without the midwives.
Thank you. We've also been joined by Councilmember Brewer, and now we go back to Chair Narcisse.
Thank you. Like we said, I'm gonna get on it for nice so we can get to an understanding. The executive capital commitment plan includes funding for various flood mitigation infrastructure projects at H&H facilities. These projects are presumably related to the risk of H&H facilities faced in the event of natural disaster like Hurricane Sandy. What will the $114.5 million capital project for flood mitigation efforts at Kohler Hospital cover, and what is the timeline to complete it?
You're going to do this?
Yeah, I do, yeah. So as we've been discussing, we do have FEMA monies available for us and set aside, and the number is $114 million at Kohler. It is our plan to spend those dollars. They were in our capital plan in the later years, and we've moved them forward, because, again, it is our plan to complete the project. It will not all happen, next year or the year after. We have, pursuant to FEMA rules, we're going to need an extension of those dollars, and FEMA is able, has the authority to grant 30-month extensions. So we're bringing those dollars in our plan to show our commitment that it is our intent to complete the project, and we will, work with FEMA to secure the extension.
Okay. So you don't have an exact timeline for it yet because you don't have the money in situated.
That will firm up here very soon, right? We will be able to produce a timeline.
Okay.
Yeah.
The capital plan includes $90 million for a flood wall at Bellevue Hospital. What details can you share on this project?
It's the same. It's ongoing.
Is the same?
Yeah, it's the same. Yeah.
The capital plan includes $35.1 million for H&H Sandy Community Development Block Grant Disaster Recovery Match. What specifically will this funding be used for, and which H&H hospital are targeted?
Yeah, FEMA has a requirement in certain instances that the city or the state will, match their funding, and the $35 million is the source through the Community Development Block Grant where we show that match. It's a variety of projects. It's just us putting up our commitment, our share of the commitment to the project. We can get you more specifics, but that's
Okay,
what
so you don't know which hospital you're gonna use it to, that you're targeting for?
It's probably a series of hospitals.
Yeah. Hospital.
But it is really our share of the FEMA dollars that we need to match.
Okay. The capital plan includes $24.4 million for flood mitigation efforts at South Brooklyn Health. What is the completion timeline for this project? Are the flood mitigation projects for South Brooklyn Health fully funded?
Yes, it's fully funded, and the completion date is the end of calendar year 26.
26.
That's well underway, yeah.
Thank you. And does H&H have any additional flood mitigation projects planned in the future? If so, can you share?
We do have a few. We remember the flood at Wood Hall, right, where we had to evacuate Wood Hall. That was, substantial damage to electrical systems there. So we have a project ongoing at Wood Hall. We have one at Elmhurst, and we have a few others that are in the works. But those are separate from Sandy.
One to Harlem.
Yeah,
So you were right.
yes, and one to Harlem, yes.
Okay. Mental health. The executive plan includes a one-time additional city funding of $3.6 million in fiscal 2026 for the mental health continuum. This program is a collaboration between H&H and DOHMH and DOE to provide mental health services in public schools. What will H&H funding for this program be spent on?
I invite members of City Council to come and see one of these centers because I think they're really terrific. They are focused on mental health needs, and they both enable us to see children who are having trouble in school, and importantly, the social workers and psychologists who work in them will also go into the classroom to help teachers on how to deal with disruptive behavior or children who are having challenges in the classroom, which I think is often missing, right? So you might have a wonderful psychologist who meets with a child and helps them, but most of the week is spent in the classroom, right? You need to work with the teacher to teach the teacher how to handle the young person in a way that enables them to stay safely in the classroom. And so these 16 centers both provide individual, family, group therapy for individuals, and they work with the teachers, which I think is a particularly important part.
Mm-hmm. So when you have the teachers, you don't have the paras?
Well, you could have both, but yes, I'm thinking that, you know, you work with the family, help the family to deal with the child at home, work with the teacher, help the teacher to deal with the kid in the classroom.
Okay, so the paras are present too? It's not a package, okay.
Yeah.
I know you don't have enough psychologists or psychiatrists to do all that, so I appreciate including the family, because once you include folks, they more likely can manage at home.
That is right.
The child have to go home. In our preliminary budget response, we urge the administration to baseline $5 million for our mental health continuum across the three relevant agencies. This is a program that has proved to be crucial for our students. How would baseline funding further support the program?
Well, it would help the program to grow because we currently only have a year's funding at a time. It's difficult for us to plan for future years.
Okay. You okay? All right. I will turn it over to Chair Brennan. Thank you so much. Thank you.
I'm going to turn to Councilmember Brewer, but really quick, just a follow-up from Councilmember Sanchez. She tells me she sent a letter to H&H back in December asking about these nurses. Can you make sure you respond to her?
Yes.
Okay. Okay, Councilmember Brewer.
Thank you very much, and thank you for visiting with the head of Judge Wang, because he thought you were terrific, and he's got a great program. So hopefully you can do something together.
We are, by the way.
Oh, good.
We are sending the show van on the days his court is working, so that they can send the clients directly to get services same day.
Fabulous. Thank you, Gail Brewer, for setting that up.
That
I
was well done,
appreciate
Gail Brewer. Send Gail Brewer my appreciation.
Yes. Asylum seekers. So my understanding, the executive plan has $37.4 million in federal funding for the services in FY26. The state and federal aids for these seekers have significantly decreased since, as you know, 2.5. Can you confirm that the funding reductions in 2.6 are solely due to HERC's closures and the census update?
Yes.
And what is H&H's role in the landscape as HERCs are shutting down? How you still have some?
Yes.
So what's going on?
We're down, I think, to 2.
Yes.
And the idea is that
You talking about the role in the Roosevelt? Is that when you
Yes.
say 2?
That
Okay.
this is no longer an emergency. We're working well with our sister agency, DHS, to figure out how people are part of the regular shelter system as needed. But there's not going to be, going forward, a separate HERC, which I think, again, our role was always, this was an emergency, all these people arrived, there was no way DHS could have housed them when they were getting, 500 people a day, in addition to the regular people that they had to do. But now that that's no longer the case, we should be going from emergency to a normal system.
Okay, and then the Roe and the Roosevelt are going to close when, do you know?
You know the dates?
Yeah, I think it's the end of June.
We might have to get back to you. I don't want to set an
Okay.
incorrect date, but they're closing.
Okay. Where do asylum seekers, because there are some at HERCs now, but also in general, seek medical care? Do they use many of them have New York Care, obviously.
Right. So, the way that it works best is, they're closing this summer.
This summer?
Yeah.
Okay.
Many of the CBOs that take care of people from different countries are very good about getting them NYC care, and then they work with them to get them a first appointment, and that will usually be about where they are geographically. We'll try to match the geography, and we try to spread the load. But certainly, in general, the highest number have been at Bellevue and Metropolitan.
Okay, they're not going to get Medicaid, right, or they are?
They're not going to get
Okay,
Medicaid.
some of them think they are going to get it, just FYI.
Not
No.
by the bill that got passed this morning.
Exactly. What is the total amount of FEMA funding, maybe you talked about this earlier, for asylum seeker expenses that you've claimed so far? Maybe you discussed that earlier.
We will have to coordinate that with OMB. That's their job to,
So OMB would know that number.
they will know, yes.
Okay. Is there additional FEMA funding or probably not to be claimed? Yeah, okay. The plan, the executive plan includes a reduction of $94 million in state funding in 25. Can you confirm that this reduction is due to the closure of the sites at Floyd Bennett and Creedmoor and Randall's Island, all of which are, were funded by the state, I assume?
Yes, we've taken substantial reductions from the preliminary budget, $95 million for this year and $540 million for next year. So the budget has come down significantly, right, because of the closures.
Okay. And the savings from the executive plan of $65.5 million in city dollars for 25 and 50 and 26. OMB stated that these savings reflect the city-funded asylum seeker sites that have closed since January. Can you confirm that this is what these savings reflect?
Yes, that's true, and it's in the numbers that I just gave you, the
Right.
reduction, yes.
Okay. And then we know the asylum sites that have already closed. I have that number. I guess my question is, I went to court, so I got a whole bunch of asylum seekers, because when you go to court and they're under 21 and I'm in charge of them, and they don't get deported. So I got them in my house all day long. So my question to you is, on the healthcare front, so they all have New York City care. So they will go, I send them to the Ryan Health Center. That's the kind of thing I should be doing, correct? But the Ryan Health Center, do they get reimbursed by New York City Care, or do they have to eat it?
New York City Care, right, doesn't reimburse anyone, right? That's just our way of organizing what health and hospitals always did for uninsured people.
Okay, so it wouldn't apply to any other institution, just H&H?
Right, just to H&H.
Okay, all right, thank you very much.
Thank you, Councilmember. We've also been joined by Councilmember Stevens. And with that, I think we are going to close. Chair Narcisse?
I just want to say thank you for being here, and we're going to continue to collaborate to make sure New York City remain the best city ever, despite everything happening around us. Thank you so much.
Thank you, Doc, and your
Thank
team.
you.
Okay, we're
And
going
your
to take a, say, 20-minute break, and then we're going to start public testimony. Thank you.
Quiet down, quiet down. We're going to be starting. If you like to testify, please use one of the sergeant-at-arms in the back to fill out a testimony slip. Testimony is going to begin in a few minutes. No food or drinks in the chambers. Chair, you may begin.
Okay, welcome back. We're now going to open the floor to public testimony. I just have to read this little disclaimer. I remind members of the public that this is a formal government proceeding and that decorum shall be observed at all times. As such, members of the public shall remain silent unless you're, of course, testifying. The witness table is reserved only for people who wish to testify. No video recording or photography is allowed from the witness table. Furthermore, members of the public may not present audio or video recordings as testimony, but they can submit transcripts of such recordings to the Sergeant-at-Arms for inclusion in the official final hearing record. If you wish to speak today, if you wish to speak at today's hearing, make sure you fill out one of those little slips in the back, and then we'll call you up. Once you've been recognized, you'll have 2 minutes to speak on today's hearing topic, which is the executive budget for health and hospitals for FY26. If you have a written statement or additional written testimony that you want to submit to us, just hand it to the Sergeant-at-Arms and they'll give it to us. You can also email written testimony if you don't have it with you today. You can email that to testimony@council.nyc.gov, and it's got to be done within 72 hours of this hearing. Okay, we're going to start the first panel. We have Judy Wessler, Kelvin Diamond, Bennett Massey, and Mateo Guerrero. And David Alexis.
Okay.
Yes. You can begin.
Beautiful. Good afternoon, and thank you for this opportunity to testify. Judy and I, my name is David Alexis. I'm here with Judy Wessler. We're here on behalf of the Commission on the Public Health System, a citywide community-based healthcare or advocacy organization that over the last 30 years has been championing healthcare access equity across New York City. And our mission is to ensure that all New Yorkers, especially low-income residents, immigrants, and communities of color, have robust access to a robust and equitable public health care system. I want to take a moment to, skip a little bit of what we were going to say originally, because the testimony that, or the earlier in the hearing discussion that by both chairs of the Finance and the Hospital Committee, in addition to all the City Council members, with the discussion they had with health and hospitals, addressed a lot of the concerns that we were hoping to address, and I think did a very, very good job to help kind of paint the picture of the state we're in, with the massive cuts that are going to come down from the federal government, the Trump administration. And while there's much in flux because we don't know how much the state is going to absorb and whatnot, we feel that the City Council has been doing the work necessary to prepare for what could be very catastrophic changes. And one of the things that I think I really just want to maybe restate or just really edify is that as a result of the dependence of these dollars that we get through Medicaid reimbursements and whatnot, and this hole that's going to be created, there is so much that really kind of needs to be worked out, planned in coordination with health and hospitals, who is literally going to be at the forefront of a lot of covering these gaps, of making sure that where there are shortfalls, the collaboration between community-based organizations that are oftentimes walking in tandem with the City Council, the city agencies, and health and hospitals kind of need to really be very much on the same page as this goes along. So seeing that at the end of the day, we're gonna, with the 1 million residents that really rely on these critical services provided by health and hospitals, this intensity with the closing of Beth Israel Hospital, and the assumption that, you know, not only the patients are going to go to Bellevue, the uncertainty that's happening with SUNY downstate, seeing that Kings County is which a hospital that already has a huge number of patients that it's seen, and we're seeing that potentially increase. I know Councilmember Lewis already addressed a little bit of that. But overall, all these services will increase the need for Medicaid beneficiaries who are going to be losing their health care insurance to become insured. And we don't know how many of the federally qualified health centers are going to stay in place to cover those who, without insurance, they're going to get the care that they need. So we really are hoping to be a part of this conversation with the city, with health and hospitals, around what is the plan and what is the nature of this going to look like, how we're going to continue to provide critical services for all these vulnerable communities across the city. And I'll refer to my to Judy to kind of talk about some of the initial recommendations that we've been thinking through, as you know, at the beginning of this planning process.
Thank you so much, and I just want to compliment council members for their excellent questions, and I was pleasantly surprised. I thought Dr. Katz did a great job too. So it's good to see this sort of synergy and working together. We do have some proposals that are not necessarily on everybody's table, and think that there should be, because what happened this morning in Congress, and you know, the kinds of things that we could be facing could be really disastrous, and we can't go back that far. You know, we've been there in the past, we can't go back that far. So some of the ideas are that the affiliation contracts that H&H, and I still call it HHC, has with Mount Sinai, but particularly NYU Langone, which has 3 different institutional affiliations, that they need to really be reviewed and to see if they are necessary, because there are costs associated that go outside of the public system, and we need to really think about that and figure it. And I don't know if people have seen it, but NYU Langone, they had the highest salaries and compensations of any institution in New York City, and you know, and they also had what we call a profit, they call surplus or excess revenue, on a 3-month basis, $300 million. So looking at that and looking at the potential of, you know, all of these institutions get tax exemptions. And so should the city be doing that? Should those funds that come in, or should there be funds coming in, and should they be used for public health and public hospital services? And we have a proposal, a little written proposal that we can work on more about that. But what we need to do, and I believe that certainly the council members that I'm looking at and the staff and others that we know would agree with this, that we can't go back and you know, not have access to care and have all sorts of, and we know that the private hospitals are going to be referring to the publics when Medicaid doesn't pay as much, and when people lose their insurance coverage. You know, I had a high school student that went around and looked at the policies of some of these private hospitals, and in the emergency room at NYU Langone, there was a handwritten note, which unfortunately wasn't smart enough to take a picture of, but if you don't have health insurance, go down the block to Bellevue. I mean, the clearest message in writing. They don't usually put it in writing, but this was in writing. And so we need to think strategically about ways to make sure that our facilities, our H&H facilities, have the resources needed to take care of people and be in the communities. So, and we look forward to working with you on these. Thank you.
Thank you.
Thank you.
Good morning, everybody. Chair Narcisse and council members, thank you for the opportunity to testify today. My name is Mateo Guerrero, and I am the Trans Justice Leadership Program Manager at Make the Road New York, and I'm here to share our concerns with the budget and an impact that it has particularly on trans and gender non-conforming, non-binary New Yorkers. Our trans and gender expansive communities are facing escalating threats from the federal government, including the attempts to roll back healthcare protections, attacks on gender affirming care, and efforts to undermine our civil rights. These policies are putting our lives at risk, and it is Black and brown, migrant, low income, and youth, young people who are experiencing the brunt of these attacks. This is why today we're urging the City Council to stand with us and make bold and meaningful investments in our community's health, housing, and safety. And we're asking the City Council to use every tool to expand and preserve programs and increase services and protections for trans and gender expansive care and people. So the first one is fully funding the Trans Equity Fund at $10 million and prioritize trans-led groups. The Trans Equity Fund was created to address deep disparities in health, housing, and employment for our communities. Raising the fund from $3.25 million to $10 million is not just necessary, but it is urgent. This funding must go directly to trans-led organizations that are best equipped to reach, support, and heal our communities. The second one is an investment of $15 million to protect TGNB healthcare providers under attack by federal policy. As the White House and the Department of Justice move to strip away healthcare protections, New York City must step up. Trans people rely on providers offering gender-affirming care, culturally competent care, and these providers, many of them clinics and small community-based health centers, are at risk of losing federal support. The city must allocate $15 million to ensure they remain open and accessible. And the third one is allocating $10 million to support providers caring for runaway and unhoused trans and queer youth. Too many young people in our communities are pushed out of their homes into dangerous situations. Our shelters and service providers are the best that they can, but without sustainable city support, they cannot meet the need. And $10 million is the bare minimum required to help trans and queer youth survive and rebuild their lives. The budget is a moral document, and it reflects what the city values are and whether it is serious about equity, inclusion, and care. And trans and gender diverse people, especially trans migrants, have been told for too long to wait, and we cannot wait anymore. We ask the City Council to act boldly, unapologetically, and with equity at the center. Thank you so much.
Thank you very much for your testimony. We've also been joined by Councilmember Rivera. And now we'll have our next panel. Kate Tiscus, Carmen De Leon, Annabelle Ruggiero, Richard Flores, and Alexander Harris. Carmen, you want to start? Just hit the mic. No.
Is it on? Okay, now it's on. Thank you. So thank you, Chair Justin Brannon and Chair Mercedes Narcisse. I am Carmen De Leon. I am the president of Local 768, the New York City Healthcare Employees. I am here today. Actually, I want to back up. I really want to thank Dr. Katz for his leadership. When I first came back to Health and Hospitals in 2014 as a per diem, basically working agency, there were 3 hospitals slated for closure back then. And Harlem Hospital, which is my hospital, I call it my hospital because anytime I'm offered to work per diem, I go to Harlem. I am currently on EO 75 release time from Harlem, and I will be returning at the end of my term because that's my hospital. I grew up in West Harlem. My father was in East Harlem, so that is my passion for Harlem. But I do want to thank Dr. Katz because he saved not only Harlem, but Coney Island, and I forgot what the other hospital is. But today I'm here on behalf of my members who cover anything from dental assistants to physical therapy to the revenue gatherers of the medical record specialists and many more. I have about 45 titles in the hospitals alone. The first thing I would like to urge the council is to be able to restore as much as possible the infrastructure funding. That infrastructure funding is important. Harlem Hospital, I believe it was either this past summer or the summer before, their air conditioning went down. And my members were calling, and I have to say the hospital and George LeConte, they worked very hard to get that restored back. But it impacted services, and it impacted the health care of the members that were working in the hospital. The temperatures were up to like 85 degrees in some situations within the hospitals. The other hospital that was impacted was back in October of 2023 when Woodhull was flooded out. My members stayed to help transport patients out of the ICU and also stayed to work under those conditions because there were some patients that were so critical in the ICU they could not move them. So they had to operate on backup generators. So that's really important that that funding for the infrastructure is restored, is restored as much as possible. The other thing that I came here to testify is that everything that we do with regard to infrastructure, it is a priority because it has a domino effect on my members and the communities at large. Because if we can't offer the services to them, they are not going to go outside of their community. They're going to stay there. I can tell you at Harlem, I had 4 generations at one time in the asthma room with me. Actually, it was 3, and then the child was in the pediatric side. So our communities use these hospitals. This is generational care that we are giving at these hospitals. If we can expand by supporting the infrastructure, that's a great thing. It also helps my members because it generates more jobs for specialties. So for instance, nursing, there's still, and I was at the state when we testified for this, for safer staffing levels. Those levels are not able to be followed, and that impacts every single one, especially me. I'm a respiratory therapist. So I've worked in hospitals, not just Harlem, but other city hospitals, and I've had my members come to me, tell me in an ICU because they didn't have enough staffing or because people called out because they were burnt out. They had 2 nurses working in a 14-bedded unit trying to get nurses in. That impacts my members as well because we're obligated to be able to take up the care for any ventilator patients because the nurses can't do it alone, the doctors can't do it alone. I think that the last part of it is that I've heard a lot of testimony today about how the privates would send members of a community around the block to the city hospital. I worked in that situation. We used to work at NCB, and at that time, back in 2002, that hospital that's around the corner from NCB would not accept Medicaid at all. And so I can tell you I had one patient come into my asthma room. He was having an MI, and they discharged him from that other hospital to bring him around the corner. So I think that we support the infrastructure of the hospitals and that funding for that, we can still prevent that. A lot of my members and a lot of the communities don't go to those other hospitals because they don't know if they're going to be able to be seen. Or if they cut Medicaid, those hospitals, even though we have, you have to see somebody, those hospitals by practice will will turn around and send that individual back to the city hospital. It's an expense. And so they're not going to say that, oh, no, we accept everybody, because what they're going to do is say, oh, no, we can't treat you. And if they are immigrants, people of color, those that are not necessarily educated to their rights as for health care, they will leave and they will take the AMA and go around the corner. I just, I came here with a whole bunch of other things to say, but really, I am concerned with the Medicaid cuts that happened this morning. It is going to increase that population that will be seen at the city hospitals. It is going to increase the amount of money that will be drawn out of the health and hospital system because of the inability for citizens to pay, or migrants. It doesn't matter. We have some of our own citizens that do not have Medicaid, or they lost their Medicaid for whatever reasons, and they come to the public hospitals. So I think it's kind of naive for us to think that, this will not impact or draw out money from the public hospitals. I work at Harlem. We have a huge number of...
Can you try to wrap it up first?
Huh?
Can you try to wrap it up first?
I'm sorry?
Wrap it up first. Give us a conclusion.
Okay, so I'm just basically saying, please support the infrastructure. Please support any funding for staffing. I have social workers. They are severely understaffed on social workers, and everybody's talking about mental health. Well, that's an underfunded program if you don't have that. Thank you again.
Thank you, Chairs Brannon and Chair Narcisse. Thanks, Councilmember Rivera, for being here. Thanks for this morning's hearing, and thanks to all of you and to the folks who testified, and for New York City generally for trying to push back against some of the terrible things that are happening right now. It makes me really proud to live here, as much as I'm very frightened. My name is Kate Tiskus. I work with Collective Public Affairs, and two of the initiatives that I work with are Trans Equity and the Sexual Assault Initiative, and that's why I'm here today. I don't need to tell you, because everybody has been telling you all morning, how the administration took aim straight at the head of trans people very first day in office, and really regards all health care for anyone who's gender nonconforming as gender affirming, and is trying very hard to make it impossible to access. We're here to really support the City Council's courageous decision to put in their executive budget response $15 million to support healthcare providers who are providing that gender affirming care and about to lose a lot of federal funding for doing so. $10 million for runaway homeless trans and queer youth who are going to sort of need additional support because their healthcare access is going to get even shakier, which tends to leave a lot of people without housing. And $10 million to the Trans Equity Discretionary Fund, which helps get people into institutions, nonprofits, care, to try to sort of stem some of the bleeding. I also want to note that the only part of sexual assault funding that comes, the only people who do sexual assault training, the only people who do survivor support, that funding all comes from the City Council. It doesn't come from the state, it doesn't come from the mayor's side. Looking for an increase to $2.5 million to sort of stem the gap for folks who are survivors who are also going to lose coverage. We're in the middle of a moral emergency, and I really appreciate that this council is almost unique among government bodies stepping up to try to answer it. I think these hospital funding priorities will literally save lives. So thank you for being here today.
Hello, I'm Dr. Annabelle Ruggiero, and thank you for letting me have the opportunity to speak. Today, I am speaking on behalf of myself and other members of Transsexual Menace New York City. To be explicit, our organization receives no money from the City of New York, nor expects to in 2026. I'm here in support of the NYC Trans and Queer Provider Advocacy Coalition. Let's start by contextualizing the Trump admin's treatment of trans people. On May 6, 1933, the Nazis conducted their first organized book burning. Their target, Dr. Magnus Hirschfield's nonprofit and its medical records and research. The Institute of Sexology was at the frontier of gender-affirming care. On February 12, 2025, the National Park Service removed all references to trans people from the Stonewall National Monument, which is located right here in Manhattan. I don't have time to cover every injustice here, but my point is that trans people are threatened by fascism today. There are actual, very real parallels between the Nazis' attempt to eliminate trans people and Trump's attempt to erase trans people from public life. With that in mind, let's look at how much money our coalition is asking for from New York City. Based on census data, a conservative estimate of the number of trans people in New York City is about 50,000. I must stress that this is a lower bound. Our coalition is asking for $35 million. That sounds like a lot, but that's only $700 per trans person in New York City. We're fighting a fascist federal administration. $700 a person is a modest request. That said, I think more than what our coalition asked for. Magnus Hirschfield's personal motto and the motto of the Institute of Sexology was per scientiam ad justitiam, which is butchered Latin for through science to justice. In that spirit, we can find some new ideas from scientific literature. There's plenty of promising review studies on unconditional cash transfers. I'd argue that the research reaffirms Hirschfield's belief that welfare yields benefits to society in excess of the original expense. While I'm an engineer and not an economist, I do personally believe that the best way for New York City to provide funding is to achieve trans equity would be to give trans people money directly, with no strings attached. And this should be done above the $35 million we're asking for. And if I can take one more second, I just want to make something explicit for the record. If the federal budget that the House passed actually makes it through the Senate side into law, people are going to die across this country. And I am very, very afraid. Thank you.
Thank you.
Good afternoon, everyone, and thank you to Chairperson Narcisse, Councilmember Brennan, and Councilmember Rivera for having this hearing today and allowing us to speak. So my name is Alexander Harris, feel free to call me Allie, and I'm the Interim Manager of Public Policy and Advocacy at Callan Lord Community Health Center, which is a health center that is providing affirming care to all that are LGBTQ+, folks who are living with HIV, and anyone who comes through our doors, regardless of the ability to pay. We're an FQHC, for Federally Qualified Health Center, and we are operating still with 3 sites across the city. I want to thank you all for the opportunity to testify today on behalf of our patients and staff and our stakeholders that we work with on a day-to-day basis. And I'm going to take a moment of vulnerability, so bear with me. Over 16 years ago, I personally arrived in New York City in the middle of the Great Recession. I had maybe $200 in my bank account, aka to my name, a promise of a minimum wage job, and a friend's couch to sleep on for a few weeks. In this moment of my life, the only certainty I knew was that I needed to medically transition to survive whatever challenges came my way. Without health insurance benefits, Callan Lord enrolled me as a patient without hesitation. In addition to starting me on gender-affirming hormone therapy, I received essential services otherwise inaccessible to me because I was uninsured. Thanks to gender-affirming care, I managed to obtain my master's in public health, and I still give back to New York City's communities as a community-based health researcher, a public servant at the Department of Health and Mental Hygiene, a program administrator, and a policy advocate for gender-affirming healthcare benefits. I am living testament to why gender-affirming healthcare matters. Without it, I would not be living the life in service to LGBTQ New Yorkers, let alone speaking with you all today on this matter. Over the past 4 months, I'm sure you're aware, federal policy changes, executive orders, administrative downsizing, programmatic budget cuts, and research grant terminations demonstrate a clear message to transgender and gender-diverse communities right here in New York. We are not people, and our lives are expendable. Due to these rapid changes, institutions like Callan Lord face new struggles in addition to supporting our transgender and gender-diverse patients living in a state of fear, abject panic, and sheer anxiety and anticipation of not knowing what's going to happen the next day. Funding previously available for LGBTQ health, HIV prevention, and health research has evaporated. Callan Lord alone has already lost $500,000 annually in programming and $1.5 million in research grants specifically for trans-specific HIV prevention, mostly focusing on adolescents ages 13 to 24. We expect this dedicated funding for trans and gender diverse New Yorkers will continue to dwindle across all social services. With the proposed budget reconciliation bill in Congress, which is now actually passed, Medicaid cuts will devastate New York's safety net institutions further. As you may be aware, in New York City alone, nearly 850,000 residents, which translates to 2,300 or more of our patients at present, and millions of billable hours and visits across our healthcare services, will lose health insurance coverage completely. Buried within this bill's reconciliation language, I want to note two harmful measures that really affect our folks at Calvin Lord and our diverse New Yorkers across the city. Specifically, Medicaid and CHIP funding for gender transition procedures for minors will be completely prohibited. ACA marketplace plans from will be prohibited from including coverage on gender transition procedures as an essential health benefit, which will specifically affect Calvin Lord, but also our health centers across the country offering gender-affirming care. Despite these threats to our patients, Calvin Lord remains dedicated to serving Calvin Lord continues to remain dedicated to our 23,000 patients annually. And what I want to make a note here too is that this is not inconsequential. This care what we're talking about, it actually offering it at a primary care level, lowers emergency room visits, improves chronic disease management, and keeps our people living with HIV, our patients living with HIV, which is something we have so much activism around New York City and globally, virally suppressed. We have this evidence from our data here in New York City and nationally and even globally suggesting that we are able to control and provide a better level of care and life for folks broadly, and our local evidence backs this up. When I mentioned our 23,000 LGBTQ patients annually, I want to recognize that we have over 8,000 gender diverse, transgender, and non-binary patients. We remain steadfast in our mission, and we cannot offset these harms without your support. And I urge you as the New York City Council to invest in us and invest in trans futures, which would mean $15 million to safeguard gender-affirming care for institutions like Calvin Lord, like H&H, and the folks across the city who really provide these services of care. $10 million to expand housing for LGBTQ youth, which will be further mitigated or further erased or decreased significantly nationally, which means New York City will have a harder capacity to address those concerns, let alone address the probably rising threat to them broadly. And we're also asking for $10 million for a revitalized trans equity fund that prioritizes trans-led organizations because Calvin Lord is one institution, and we are collaborators and we work with our stakeholders across the city in order to ensure that every person's care is taken care of. When I say we do case management services, I mean housing, I mean enrollment and benefits, I mean things far beyond the services that we provide, which typically are about primary care, dental, behavioral health, and et cetera. But we can't do it all. If someone needs a pantry for their food or otherwise, we can put them there, but we are not the ones who are able to support those services directly, let alone take on the financial disparity that we're going to experience with these Medicaid cuts and these cuts for services that are essential to gender-affirming care.
As New Yorkers, do a conclusion for us?
Yes.
Thank
As
you.
New Yorkers, we all have an ethical responsibility to protect each other, and now is the time to act. I really want to thank you for your time today, and the time you've offered us, and Calvin Lord provided its written testimony along with mine for the record. Again, thank you so much for listening.
Thank you.
Thank you for allowing me to testify today. I understand that this budget meeting is for cuts that are happening citywide to residents.
Unfortunately, it's not us, it's coming from the federal. We're trying.
I'm currently a Blue Cross Blue Shield member, and I have Medicaid and Medicare. Though I don't have the current numbers and data present with me, I speak for myself and many others when I say that the American healthcare industry, I believe, is in dire jeopardy, as everyone here has stated. I've been denied emergency room treatment at Flushing Presbyterian Hospital after being misdiagnosed for various medical conditions for over a decade. Instead, I was illegally forced to involuntary mental health evaluation, even though I was there for a physical ailment. I believe this is being utilized to treat various illnesses, mental health, physical health. I understand that. But I was actually denied medical treatment, and I was sent on my way without being treated at all. And despite the fact that U.S. law states that every citizen has a right to health care, it seems to me, if you don't mind me saying, that there seems to be a permanent underclass that has fallen victim to what I like to call in literary terms sickness on to death, as the Christian existentialist Soren Kierkegaard once wrote. Too many times I've seen mentally ill homeless persons in various states of distress, and they deny medical care after they've fallen ill or simply have gone somewhat insane after indeterminate periods of time without health care on the street. So in ending, it seems that what's apparent is that there needs to be re-legislation of the law in order for there to be able to ensure medical care for all American citizens. And though it's true that the cuts in Medicaid and Medicare via the Trump administration is being used as a culprit, I'd like to know what's happened to the Hippocratic Oath by law. You go to the hospital, you have health insurance, you're covered by Medicaid, you're covered by Medicare, but often too many times you don't receive medical treatment or adequate medical treatment. And if I can be so honest to say, I think that it shouldn't matter about your gender, it should matter that you're a human being and you need medical help. Whether you're young, whether you're a baby, whether you're an adolescent, whether you're a teenager, whether you're an adult, a senior citizen. And it shouldn't matter what race or nationality you are. We have the greatest healthcare system in this country. And there shouldn't be any reason, I think, even despite what's happened in the world with COVID-19 affecting people on various levels, that they shouldn't get adequate healthcare if it's actually there. And that's all I'd like to say. Thank you.
Thank you all for your testimony. Okay, now we have Kelvin Diamond and Bennett Moss. Please turn your mic on. There's a button on the bottom there.
Okay, good afternoon, chairpersons, members of the City Council. I'm Bennett Mossy. Beside me is Kelvin Diamond. We are delegates of the Organization of Staff Analyst Union and employees of New York City Health and Hospitals. On behalf of our members, I would like to thank the City Council for their ceaseless commitment to New York City Health and Hospitals and the health care of all New Yorkers, regardless of income. Thank you again.
Thank you. Thank you very much. Okay, now we're going to move to Zoom. If you're currently on Zoom and wish to speak, we're going to call you. There's nothing to say. Whitney Walton.
You may begin.
Hello, good afternoon.
Good afternoon.
So my name is Whitney Walton. I am a behavioral health social worker with Jacoby, and I am a member of DC 37, Local 6768. And I'm grateful for the chance to speak with you today. So like I said, thank you. As a licensed social worker, we are critical to our mission here at Health and Hospital. Many provide essential daily services with their foundational licensed master social worker, or other known as LMSW credential. But I want to take the time to highlight the advanced capabilities of our licensed clinical social workers, our LCSWs. So achieving the LCSW requires years of additional dedicated practice, significant personal investment, and passing rigorous examinations, representing a deep commitment to providing the highest level of care. While working in a demanding hospital environment and critically across the diverse communities we serve, LCSWs are the forefront of addressing escalating mental health needs. They offer expert clinical guidance and therapy, often to our most vulnerable populations. This advanced level of practice and the demanding path to achieve it, especially in the face of such significant community needs, must be reflected in our compensation. Therefore, I am strongly proposing that a prorated annual differential established for all social workers who earn their LCSW from the New York State Department of Education. This is more than fair compensation. It's a vital strategic investment, recognizing that the LCSW will directly boost morale, significantly improve the retention of our experienced clinical staff who are essentials for our mental health service delivery, and unlimited strengthening the community and quality of comprehensive care, including what we have spoken about
Thank you. Your
here.
time expired.
Okay, sorry.
Thank you very
I
much.
just want to say thank you. Thank you.
Thank you, Whitney. Now we have Avi Severino.
You may begin.
Good afternoon. My name is Avi Severino, and I'm a trans individual from the Bronx. And I'm here today calling on the City Council to maintain and expand the $15 million investment towards gender-affirming care across New York City. I come before you just not just as an advocate, but as a living testimony to what this funding makes possible. A few years ago, I experienced one of the most severe mental health episodes of my life while dealing with gender dysphoria. But thanks to the gender-affirming services funded here in New York City, I was able to access affordable care thanks to Callan Lord. Gender affirming care saved my life, and without access to those services, I would not be here in front of you today. I represent just one of over 50,000 transgender individuals in the city who could tell you a similar story because without access to gender affirming care, um, too many of us are left without the support we need to survive. And as we witness a rising wave of anti-trans legislation and hateful rhetoric sweeping across the country, it's critical that New York City not only holds the line, but leads with bold action. That's why I also strongly support the expansion of other trans equity initiatives in this budget, like increasing the New York City Trans Equity Fund to $10 million, as well as investing in shelters for trans youth. In this moment, the city must do everything in its power to ensure that we remain a safe haven, but this legacy is not self-sustaining. It must be actively protected. Let New York City not just be remembered for where the fight for queer liberation began, but for how fiercely we chose to protect it and how boldly we showed up for trans lives when it mattered the most. Thank you, Council and Chair, for listening and giving us the floor to speak.
Thank you, Avi. Now we have Simone Sun, or Simone June.
You may begin.
Hello, thank you to the Council, Chair, and Committee for allowing us to speak today. As many before have mentioned today, and as you all have been transparently discussing, the current federal executive and legislative attacks on public health care, particularly on transgender care and transgender people, is of a dire issue of our time. I, like many others before who have spoken, am a testament to the benefit and wealth and necessity of gender affirming care needed to be provided by any means necessary. I speak today as someone who received gender affirming care funded in part by New York City at a federally qualified health center that depends on public funds. And so I am here today to ask that the New York City maintain and expand the $15 million directed to gender affirming care in New York City, as well as to increase the funding for the Trans Equity Initiative Fund, as well as the creation of shelters for trans youth, potentially for those who may be fleeing to New York City because of nationwide anti-trans oppression that is going on. I would like to thank the committee and council for giving us the opportunity to speak and for fighting for the rights of all New York, and making sure that we get the rightfully owed healthcare that we all are rightfully owed. Thank you.
Thank you. Now we have Martha Larson.
You may begin.
Hi, I'm Martha. I'm a primary care social worker at Bellevue Hospital. I've been here for 5 years. I'm here because I'm active in my union, local TC37, local 768, and I want to talk about some of the needs of the members of my local. I also want to speak to some of the things that we're hoping to get in our contract, just like Whitney was talking about. We did a survey of the membership last year, and we found that the most important economic demands for members are for longevity and licensing differentials. City hospital social worker turnover is a problem, and certain areas struggle more than others with retention. We need ongoing differentials for longevity. We do currently have them in our contract, but they're low, so they need to match inflation. And we need differentials for licensing, something that Whitney was talking about. There's currently no differential for people to get their clinical social work license, which takes time and money to prepare for. And city hospitals are now billing more for social work services. This is really important to retain quality workers. Otherwise, social workers will go work elsewhere. I also want to speak to demand for a language differential. As you all know, we see a very diverse population that speak many different languages. Currently, bilingual staff do not get any salary differential, and bilingual social workers are often given differentials in different places, other jobs. So it'd be hard to recruit and retain social workers that speak languages that our patients speak. Thank you so much.
Thank you. Now we have Carrie Hawks.
You may
Hello.
begin.
Thank you. Thank you for allowing my testimony today. My name is Carrie Hawks, and I'm a trans New Yorker. I just want to reiterate that trans care saves lives, particularly when trans people are facing hate and violence around the country and around the world. The best suicide prevention is an accepting and supportive environment. That means our homes and our cities and our medical professionals. When I was a trans teenager, I almost didn't make it to adulthood because I didn't have the support I needed. And there's a reason that I moved from Missouri into New York City, a city that respects me. At this time, I'm asking the City Council executive budget to include the $15 million directed to maintaining and protecting access to gender affirming care in New York City. I support the NYC Trans Equity Initiative, including increasing the NYC Trans Equity Fund to $10 million to support organizations supporting the trans community, to increase funding for the creation of shelters for trans youth fleeing to NYC because of anti-trans oppression, and in the face of ongoing and escalating attacks on the trans community, particularly attacks against gender-affirming healthcare by the Trump administration and other peoples across the country. The equity for transgender New Yorkers is already disproportionately faces will increase if the city does not step up. So I'm asking also that we not give in to this rhetoric to let our rights be stripped away, because the Trump administration will try to prohibit the use of federal health care, including Medicare, Medicaid, and others for gender-affirming care. This threatens access to the necessary and life-saving gender-affirming care for all trans, non-binary, and gender non-conforming and expansive New Yorkers, most especially those who rely on publicly funded health care. Thank you so much.
Thank you. We've been joined by the Majority Leader, Councilmember Farias, and now we have Christopher Leon Johnson.
You may begin.
Yeah, hello. My name is Christopher Leon Johnson. Thank you, Chairs Brandon, Majority Leader Farias, and Chair Mercedes for having us here today. So I'm gonna dive into this right now quickly, and I want to call on the City Council to add the Worker Justice Project and the Street Vendor Project into the crisis management system program, which will get them availability to access the funding for cure violence initiatives, because there's a lot of street vendors that go through a lot of harassment with NYPD to the point that selling that goes to the hospital. And at the same time, a number of these deliveries get hurt on the street by people in the city of New York, and the street vendors too. So when they go into the hospital, I know that there's a big language barrier, and majority of these guys and gals have a language barrier, and it's a racial barrier. So they need to be able to speak to the people that they trust, that they know they can trust, which is their own people, which is mostly Hispanic people. And the Worker Justice Project and the Street Vendor Project are full of Latinos members, so they should be able to conversate with them more, just like the Cure Violence organizations that are full of African Americans only deal with the African Americans with the like Life Camp and Man Up Inc. So I'm calling the City Council to add those two nonprofits to the crisis management system, so they're able to access the funding like the crisis management system getting, which is up to $100 million. I believe that both organizations should get $1 million out of that pie, out of that bucket with the cure violence organizations. And I'm calling on the city council, Mr. Brandon, Mr. Justin Brandon, on the 30th of this month in May at 6 o'clock at 6 p.m. at the 30th at 6 p.m. I'm calling on you, our so-called income controller, to come out with a bike and bike down with us for the critical mass to City Hall starting at 6 o'clock up in Union Square. We're going to City Hall with a lot of Transall and all these organizations. We're here to show solidarity with everybody who's been arrested by NYPD officers and get summonses by NYPD officers. And we don't know how that goes. If you don't want to take a summons, you go to the hospital because we don't know what's going on police suppression.
Thank you. Your time expired.
I'm calling you, Mr. Brandon, to come out and show support on that day. Thank you.
Okay, now we have Nate Franco.
You may begin.
Good afternoon, and thank you for hearing us in this testimony, Honorable Chair and Council members. My name is Nathan Franco. I'm a social worker at Harlem Hospital, where I've worked for 15 years, working on the inpatient medical units to support patients in their transitions out of the hospital to their next level of care, including the orthopedic patients that Dr. Katz referred to earlier with the HSS collaboration. I believe in the work we do. I take pride in helping my patients have the best possible chance for recovery during what is often the hardest time of their lives. Social workers are an essential part of our healthcare, providing both direct patient care through our clinical services, as my colleagues already mentioned, and also helping patients navigate the complex healthcare systems we have. Dr. Katz talked about navigation earlier, particularly in regards to cancer care, but it does apply to many other aspects of the healthcare system. Where in these cases, a simple misplaced fax or an unreturned voicemail can lead to devastating consequences as care is not utilized or followed up on or made available. Over the past 2 years, Local 768, of which I'm an officer, has surveyed our members who are social workers in H&H to explore how caseload and productivity expectations have impacted quality of care and worker retention, among the other issues that my colleagues have talked about. The results found that 2/3 of H&H's social workers believe their caseloads are not appropriate and 97% of them believe that the quality of care suffered as a result. The findings demonstrate an overwhelming agreement across social workers of all assigned areas that an enforced limit on caseload would improve quality of care, improve work-life balance, and increase the desire to continue serving our city through health and hospitals. We have initiated discussions with H&H about establishing caseload limits as they have been accomplished for registered nurses through state staffing legislation, though the limited funds available to H&H, only made worse by the federal bill we've all been talking about, represents a barrier to
Thank you. Your time expired.
Thank you.
Thank you very much.
Can you conclude for me, please? Because I'm listening to what you were saying about that.
Gladly. Similar to class sizes in the DOE that the DOE is obliged to follow, H&H needs the appropriate funding to establish caseload limits. These have not been, agreed to in any way yet. While some areas of work, such as outpatient behavioral care, are eligible for insurance reimbursements to support staffing salaries, much of the work we do is in the context of capitated payment rates for inpatient services. So social work time does not get directly reimbursed by insurers. So as a result, our suggestion is additional funding to develop this caseload limits and fund the necessary staffing increases. And we very much appreciate you hearing us today. Thank you.
Thank you.
Okay, with that, this hearing is adjourned. Joint Committee on Finance with the Committee on Hospitals. Thank you.
Thank you.